I'm Tegan Taylor, a health and science reporter at the ABC and co-host of the multi-award-winning CoronaCast, and I am delighted to be hosting UNSW's Faculty of Medicine and Health's first MedConnect event for 2022. The topic today is certainly front of mind for many in our community, directly or indirectly, putting the brakes on dementia. Today we will be exploring the impact and future of dementia in our society. 1 out of every 5 of us who have reached late middle age can expect to develop dementia. In 2021, there were an estimated 500,000 people living with dementia in Australia, and around 1.6 million people involved in their care. That number is expected to triple by 2050, unless there is a medical breakthrough. In economic terms, every year dementia costs the economy in excess of $6 billion in healthcare and loss of productivity. And the impact on loved ones is devastating. Before we begin, I'd like to acknowledge the Bidjigal and Gadigal peoples of the Eora Nation, who are the traditional custodians of the lands I'm joining you from tonight, and the traditional owners of all the other lands each of you are joining from. I'd like to pay my respects to the elders, both past and present, and extend that respect to our Aboriginal and Torres Strait Islander colleagues and friends who are joining us here today. And now it's my pleasure to introduce you to the MedConnect at University of New South Wales, a digital event series through which we explore key health issues affecting our community, in a forum that brings together health leaders as well as industry experts for what we hope are lively and thought-provoking discussions. You can ask your questions as well via Slido. The hashtag for the event is #MCDementia. McDementia. Through Slido, you can also upvote other people's questions, which will help us to prioritise the most important questions, and you can lodge those questions at any time throughout the event. A reminder that this webinar will be recorded and made public following the session. Now, let me introduce the panellists joining me this evening. Welcome to Professor Graeme Samuel, AC, a professor in Monash University's Business School and School of Public Health and Preventative Medicine. He is chair of the Dementia Australia Board and chairs the Australian Dementia Network Limited, ADNET, among others. His former roles include chairman of the Australian Competition and Consumer Commission, associate member of the Australian Communications and Media Authority, and president of the National Competition Council. He was chair of the Commonwealth Government's panel on review of Australia's independent medical research institutes and advisor to the Commonwealth Department of Health in its review of private health insurance. In 2010, he was made a Companion of the Order of Australia for eminent service to public administration through contributions in economic reform and competition law, and to the community through leadership roles with sporting and cultural organisations. Graeme, it's a huge honour to have you joining us tonight.
Thanks, Tegan.
We also have Dr. Stephanie Ward, Senior Research Fellow with the UNSW Centre for Healthy Brain Ageing. Stephanie is a geriatrician who is passionate about improving the quality of diagnosis and care for people living with dementia. She is the Clinical and Initiative Head for the Australian Dementia Network, ADNET, Clinical Quality Registry at UNSW's Centre for Healthy Brain Ageing, CHeBA. ADNET is a nationwide initiative bringing together consumers, clinicians and researchers to improve research opportunities and clinical care for those at risk of and living with dementia. Stephanie's clinical practice inspires her to engage in several studies investigating the mechanisms of or prevention of cognitive impairment and dementia. One such recent area of interest is the role of intergenerational contact in healthy ageing, and she was the expert geriatrician on the award-winning ABC series Old People's Home for 4-year-olds. Welcome, Stephanie.
Oh, thank you. It's great to be here.
I'm not at all intimidated by the brains we're about to be chatting with tonight. Welcome to the panel. Thank you everyone for joining us this evening, and let's get stuck straight into it. And Stephanie, I'm going to ask you just to help us set the scene. We often hear people using the words dementia, Alzheimer's, cognitive decline kind of interchangeably. Can you help us set the scene of what we're talking about when we're talking about dementia?
That's such a great question. So many people have that question, including other doctors. When we're talking about dementia, what we're talking about is a clinical syndrome. And it's a clinical syndrome characterised by a change in what we call our cognition, which is essentially our thinking skills. Thinking skills that include memory, but also things like attention, language, our ability to plan and make decisions and orient ourselves in our space. and a change that is sufficient to make day-to-day life more difficult than it used to be. And we don't have another reversible excuse for this. It's not occurring because we're medically unwell or because it's a side effect of a medication. And dementia is often accompanied by something else called mild cognitive impairment, in which there's a change in our thinking skills, in our cognition, but not to the degree that it's impacting upon our day-to-day life. So it's a clinical diagnosis. It's made by taking a history from somebody, and from somebody who knows that person well, by doing an examination, by reviewing investigations, and by doing cognitive testing. And of course, with all clinical diagnoses, there are limitations with that as well. And like all clinical syndromes, there's usually more than just one thing going on. So there's often a number of changes in the brain that are the reason why somebody develops dementia. So Alzheimer's disease is what most people have heard of. Is it the same as dementia? Not necessarily, but Alzheimer's disease is the most common cause of dementia. We find changes of Alzheimer's disease in around 70% of people who are living with dementia. There are other causes as well, of course. So other common causes are things like changes to blood supply, what we call vascular dementia after a stroke, for example, or tiny changes that happen to the deep blood vessels that we don't really know about in day-to-day life but are accumulating over time. There are also dementias that occur in conditions related to, say, Parkinson's disease type pathological changes. So you get dementia in Parkinson's disease or something else called dementia with Lewy body. There are some types of dementia that affect the front part of the brain and present with different features. And then there are multiple other types as well, including pathological types we're still understanding. And it's that heterogeneity of different causes which I think adds to the complexity of diagnosis and care. I hope that answers the question, Tegan.
Well, when Stephanie answers it so clearly like that, it's hard to believe that so many people find it hard to get a good diagnosis. But Graeme, that's the case for so many people, isn't it?
And that's probably one of the most heartbreaking aspects of dementia, is that there's not enough expertise around, either at general practice level or, frankly, even amongst some geriatricians as to the diagnosis of dementia. Now, Stephanie's described the complexities that we're dealing with, and the complexities are very significant indeed. But so often people will say, oh, that patient of mine has a cognitive decline. You know, it not behaving the way that you'd expect him or her to normally behave. So therefore must have Alzheimer's disease. No, not at all. And when you start challenging those sort of things and people say, well, how do we find out? Well, there are so many different tests that can be applied, including things like MRIs, PET scans and the like, to try and diagnose exactly what's going on. Why do we have to do that? Because the remedies, if there are any, are entirely different. I liken dementia in many respects to cancer. Now, there are so many different forms of cancer. And if someone is diagnosed having cancer, you just say, oh, that's good, there's particular chemotherapy that will apply. No, that's not so. We all know that there are so many different forms of cancer requiring different remedies, different means of dealing with it, different prognoses. Dementia is the same. And the difficulty that we have with dementia is that at the moment we don't have any known cure or means of prevention, with a couple of lights at the top of the hill, a couple of beacons that are there that might provide some hope. But the problem is that at the moment it's one of those diseases that becomes ultimately inevitable. The other element of dementia that we find extremely difficult is that there are people who know that they have some form of cognitive decline, but they don't want to admit they've got dementia because they're worried about the stigma associated with it. And so one of the big tasks that we have is to remove that stigma, to say this is no different to any other disease. It is a disease, it's a disease of the brain. It causes changes in behaviour, causes changes in your cognitive ability, and that's the sort of thing we just, you ought to be able to live in society with that disease the same way as you can live with any other disease in society.
I really want to talk about treatments and management in a little while, but Stephanie, I know that for some people that come to you with cognitive decline, for a small, lucky proportion of them, it is something reversible.
Yeah, and that's such a great point. And some studies would suggest that it's up to perhaps 20% of people presenting with worries about memory and thinking, we can identify a cause that we can actually do something about. Most commonly, things like side effects of medications that can affect the clarity of our thinking, particularly as we get older and more vulnerable to side effects. It can sometimes also be things like untreated anxiety and depression that, when adequately treated, improves the clarity of our thinking. Occasionally, we find things such as specific types of dementia that can have specific types of treatment, such as something called normal pressure hydrocephalus, when there can be some swelling in the inside part of the brain. It's very rare, but that's, I think, underpins why it's really important to have a thorough assessment, because a thorough interrogation can identify things that we can do something about, and that can be really reassuring to people. And I think the other part is that understanding what's happening when you notice something's changing and the diagnosis is dementia, it's that first part of the journey towards taking control and living the best life you can.
What is best?
I can say, can I give a couple of totally contradictory examples? Right. So, a colleague of mine recently was showing some real serious cognitive decline, memory lapses, confusion, and the like. And his family sought my advice, and I suggest they go and see a very qualified geriatrician in Melbourne who has significant expertise in dementia. And he examined the individual concerned, and he said, "What medication are you on?" He said, "Well, I have bad eczema and I'm on high doses of cortisone." He said, he found out what it was. He said, "I want you to tone those back." And the individual said, "But hold on, if I do that, the eczema will exacerbate." He said, "Don't worry about that." He said, "I want you to tone it back." He toned it back, and lo and behold, the cognitive decline disappeared. So that was the side effect that Stephanie's talked about. Now, on the other hand, you can have situations where, for example, someone shows some cognitive decline, and this happened with my late mother, and she had some cognitive decline that was showing up, and her GP, a lovely guy, very, very experienced, but he said the problem is grief over the sudden loss of her husband, then it was depression, and all those things were happening, and then ultimately we took her to a geriatrician, an expert, and he said, half an hour. He said, she has dementia. So they're the converse factors, and that's why it's so terribly important. Generally, our experience is, and Stephanie I think will confirm this, that it takes about 3 years for someone who's showing cognitive decline to get expert diagnosis as to really what it's about, and then sometimes you won't really know.
And that's 3 years that you're not treating that person.
That's the problem.
With best practice.
Yeah, and sometimes I've also heard it, but about half of that time might be recognising there's an issue and being brave enough to seek help. And part of that time is some inefficiencies in the healthcare system as well, in terms of recognising it, responding to those concerns, being able to access a diagnostic service and then await for that diagnostic service as well.
So what does best practice around diagnosis look like?
That's a great question.
I'm asking so many great questions.
You are. But it is, because what is best practice? Well, I think best practice is that people have their concerns taken seriously, first of all, when they raise them with a healthcare professional. There's a basic screen done for any potential red flags or possible explanations. Basic level of investigation is often great as well, to make sure we're not missing some of the really obvious things that can affect thinking. As we mentioned, medications, or, for us, it's often side effects of really strong painkillers, for example. I think best practice is knowing where you can go for more specialist diagnosis if that's what's needed, that it's easy to get a referral, that you don't need to wait very long, and that your concerns are listened to, and you're part of that conversation the whole way, including whether you want to know the diagnosis or you don't. That's a really funny question, but some people may not wish to be told the diagnosis, and I think what's really important for us is to elicit what people want to know and what family members want to know. And a good diagnosis is thorough, and it's person-centred. It's really understanding the history of what's happening and other health issues as well, and remembering that the brain exists within a body, and that body exists within a social construct as well. So understanding other health issues and a person's social circumstance and understanding a person's pre-morbid function as well. Was this somebody who has 5 degrees? Did this person not speak English as a first language? Let's choose the right test to do and investigate a person appropriately. So there's a range of investigations that can be done. Usually we'd look at some structural neuroimaging, so having a look at the brain, and sometimes we might go on to additional investigations as well that you mentioned, Graeme, such as more functional measures of the brain, what we call looking at how the brain is functioning. But that won't be needed for everybody, and it probably wouldn't be practical for that to happen to everybody, given that we estimate maybe 80 to 85,000 Australians are diagnosed with dementia every year. And a diagnosis needs to be discussed with the person themselves. And the information needs to be given in a sensitive way. And the amount of information given really needs to be tailored to that individual person. And what else is important is that we create a sense of hope as well, because it's a huge thing to hear. I've heard probably too often some people say that they've been told, well, it's just dementia, there's nothing we can do, go away. It's just old age, there's nothing we can do. And we want to move away from that, because that's not the case at all. There are things we can do to make life better, and things are going to get better and better as years go on, particularly with increasing excitement and investment in interest in research and new interventions to trial.
So, I just want to take that, because that's really important. If you'd asked either of us 2 years ago, we'd have said, just don't know what you can do. There's very little that's there. But there are 2 elements that Stephanie's mentioned. The first is we are starting to find drugs that might, let me underline the word might, that might just provide some method of prevention or delay. And that's important. Not yet cure, but certainly delay in the onset of symptoms, particularly in relation to Alzheimer's disease. Number 1. Number 2, it's terribly important that if someone is diagnosed as having a particular element of dementia, whatever it might be, that we, as carers, as loved ones, that we arrange for their living circumstances to be such that they can live as full a life as they've always been able to do, because that, in many respects, that's so important in delaying the onset of the disease, the onset of symptoms. One of the things that at Dementia Australia we've always talked about is trying to keep people who have been diagnosed with dementia living in the community, engaging in a social life and a productive life for as long as they possibly can. It's an important element of it. Keeping exercise going, keeping the brain active and the like, all those things are terribly important. They're important for 2 reasons. One, because they will give the prospect of delaying or preventing the continued decline in cognitive ability. But the other one element of it is its dignity, living with dignity, living with a sense of satisfaction and fulfillment of life. So it is really important. I want to go back just very quickly, Stephanie, to one element of this, and that is that when you are concerned about your cognitive ability and whether you're suffering memory lapses or confusion, or you detect it with a loved one, you wonder where to go. And there are so many GPs that don't actually know how to diagnose, and they probably don't know necessarily which geriatrician to refer to. One of the things Dementia Australia does is it has a helpline. It's acknowledged as sort of as the door opening for the roadmap. It's 1-800-100-500. I'll repeat it, 1-800-100-500. And that is if you like, it's the door that says enter that, call the helpline, and from there you can be directed and given assistance into so many different aspects. Where you might be able to go to get the proper diagnosis, where you might be able to get some care. Importantly, how it is that you can, if you're a loved one helping to care for someone who is showing cognitive decline, how you can actually modify elements of their living conditions, their home and the like, to deal with it. And there are so many different factors. Unfortunately, when someone starts to show a significant cognitive decline, then issues like driving licenses have to be reviewed. Now that is, for so many people, one of the most devastating aspects, to have a driving license removed. But it's unfortunate, and sometimes has to be done. The other thing that Stephanie mentioned, which is so important, sensitivity. Because when you say to someone, you have dementia, if you put it like that, it's devastating. And sort of caring geriatricians, caring doctors know how to sensitively sort of deal with this issue, particularly as there are many persons who will be in denial. What are you saying to me? That cannot possibly be right. And that's where it's so important to have someone who's skilled not only in diagnosis, but skilled in actually dealing very sensitively with his or her patients.
Human beings. Just a reminder that you can ask questions tonight by using Slido. The hashtag is MCDementia. We're going to start getting to some of those questions in a moment. But let's talk about what we can do with the tools that we've got at the moment. So dementia is not reversible. It's not curable at the moment, if I'm not mistaken, but you can slow it down with appropriate treatment. Can you talk us through what that looks like?
Yeah. Do you want me to talk about prevention as well?
Let's get in there, yeah.
Because what's really interesting, and I think although we don't have a cure, we've had a lot of advances in the last couple of decades which are really important. And one of them is that recognition of risk factors for dementia, and understanding that potentially 40 to 50% of all dementia cases worldwide can be linked to risk factors that we can potentially modify. So that includes things like high blood pressure, poor control of blood sugar in diabetes, leading a sedentary life, being socially isolated, having hearing impairment that's not corrected, having a poor diet, the converse being having a good diet can be protective, having good education levels and keeping our brain cognitively stimulated seems to be protective. Potentially even poor sleep, untreated sleep apnea, and other things sometimes beyond our control, such as the level of air pollution that we live in, may have an impact on our risk of dementia and are potentially modifiable. So when we've been given a diagnosis of dementia, there are some adjustments we can make to our lifestyle that may help that progression of dementia and also may help our quality of life and prevention of some complications of dementia. For example, physical exercise. Now, not too many downsides to physical exercise, and we know from observational data that people who engage in physical exercise seem to be at reduced risk of dementia and may have a slower rate of decline. You can even see changes on neuroimaging that reflect the level of exercise and resistance training that you're doing. And even if it's not affecting your brain, it's helping your body and your muscles as well. We know that as we get older, we're at increased risk of falling over, for example. That risk increases if we're living with a diagnosis of dementia. But exercise and balance exercise and muscle resistance can help to prevent frailty, can help to prevent falls. Having a good diet, not too many downsides to that, may also be helpful. Keeping socially connected is the most fun way of keeping your brain active. And so cognitive stimulation might be really helpful. And the best way to do that is to be engaged with others. But, trying out new things can be helpful. Looking after your sleep, looking after your level of hydration, and looking after your other health factors, your blood pressure, your other health, making sure that you're on the right medications. These are all factors that can help our journey, as well as thinking about the future and planning for the future and taking control, learning about the condition, and perhaps putting in place measures to help with, say, future decision making if your dementia progresses to a point where it is difficult for you to make complex decisions. You've had organisation of people that you trust to look after those things in the future, and you can communicate your wishes as well, including around future healthcare. And while we don't have cures, there are some medications that are available on the PBS that may help the rate of decline and symptoms associated with dementia. They're called cholinesterase inhibitors. They increase the amount of chemical that our brain cells use to talk to each other. and they're approved for use in people who have mild to moderate Alzheimer's type dementia, but have also been shown to have efficacy in other subtypes of dementia, such as those related to Parkinson's disease. So while they're not for everybody, having a diagnosis enables you to have a conversation with a doctor about whether it's worth having a try and seeing if it suits you.
Now, can we get slightly technical, because there's some hope that's there on the horizon. Two things have occurred of quite some significance over in fact, since the beginning of this century. Some remarkable work has been done, as it turns out, in Australia, which is what's called the ABLE study. Now, the ABLE study has been working on a process with a cohort of about 1,000 people who have volunteered to try and see if there is a way we can find out well ahead of time that there's a potential problem, particularly with Alzheimer's disease. And it's focused on the issue that Alzheimer's disease is assumed to be caused by the development of amyloid plaque on the brain, which causes damage. It was first described to me 20 years ago, as it turns out, by Colin Masters, who's been at the forefront of this study, as amyloid as being a bit like rust. Now, when you have rust on steel, if you get it off quickly, that's good. If you let it sit there for a while, it pits the steel. You can't remedy it, you can't fix that. Now, with amyloid, we know that if it gets on the brain, in some people, it can actually do damage, and that's what leads to the potential for cognitive decline, and we have that here. So that study has progressed well down the line, and we now have what are called biomarkers, that are processes whereby we can, through a combination of blood tests, PET scans, MRIs, even lumbar punctures, we can actually find out whether or not there is a propensity for amyloid to be forming on a particular patient's brain, and then that raises the prospect of Alzheimer's disease. Now, if we can find out 20 years ahead of the time, and then we can find some means of preventing that forming, then that is potentially a way of delaying or preventing the disease through chemical intervention. What are the chemical interventions? There's been one most recently that has been discovered by Big Pharma over in the United States. It's called aducanumab. There's been a bit of a debate about that because of the way that the drug authorities in the US gave approval to this drug. But on the other hand, it is showing signs of potentially being a means of preventing further amyloid forming on the brain, and maybe even removing some of the amyloid that might be there. There are some risks associated with it, including brain swelling and the like, and Stephanie is the expert in this rather than myself. We were talking about this before we started here today, and Stephanie said, would I take amyloid? Would I take aducanumab? Would I use it if I was detecting a potential for cognitive decline? I said, yes, I would. Why? Because it's a bit like having a ticket in a lottery. If you've got I'll tell you what it is. If you've got the ticket, there's a chance you'll win. If you haven't got a ticket, there's a certainty you won't win. And so
you just talked about pretty serious side effects.
I know. So it seems to me that if these drugs are starting to emerge and providing you understand what the side effects are and the like, and providing you understand what it is, what diagnosis you have, that I would say myself, I'm prepared to take some of those risks, because I know that if I don't, then there is, on the diagnosis provided by experts like Stephanie, there is an inevitable decline. So that's, now what does that say? There is the potential, and I have to underline the word potential for drugs to be found by Big Pharma over the next few years that could potentially delay or potentially even prevent, if you get it early enough, the onset of Alzheimer's disease. Keep in mind, talking about Alzheimer's disease as distinct from the many other forms of dementia that we've been talking about. Now, Stephanie will correct all that with her scientific expertise.
Come on, Stephanie. Aducanumab's pretty controversial at the moment. And what else is also on the horizon?
Yeah, so it is controversial, and for people who are not familiar with it, it's an antibody, and it attacks this amyloid plaque. And as you mentioned, Graeme, we know that amyloid plaque, it's a sort of a plaquey thing of proteins in the brain, and it starts to accumulate a couple of decades before somebody develops dementia. Seems to trigger other changes in the brain, what we call tau, neurofibrillary tangles from developing. And as you mentioned, great research in Australia and elsewhere has shown this trajectory of changes that occurs before we even have any changes in our thinking. So of course, there's been a lot of investment of research into, well, what about if we remove this plaque? Can we treat dementia? And that underlines the aducanumab and the other monoclonal antibodies. And the controversy from the aducanumab study is that on the primary outcome of the study, on cognition for the whole cohort, there was a negative. There was no difference between placebo and the treatment arm, even though the medication was shown to clear the plaque in the brain. So on subgroup analysis, there was a signal in one of the groups, so a positive response in one of the groups, and it was approved by the FDA in America, even though the advisory board had sort of advised against it. And now Medicare in the United States will subsidise treatment for aducanumab, but only for people who are enrolled in a clinical trial. And the approval was provisional in that a clinical trial needed to report findings by 2029. So it's really interesting because basically what the approval was based on was not on the change of dementia and changes in memory itself, but what we call a surrogate marker. This amyloid disappearing, does that mean we've actually treated the disease?
Or
and on the B,
bystander?
Right. And other medications get approved on surrogate marker outcomes. But the controversy here is that we haven't yet been able to show that clearing amyloid means a change in cognition.
So it feels like
Yeah,
this is somewhere that we're inching towards our goal.
Yeah.
What research is required? Like, what does the next 10 or 20 years involve in terms of figuring out a way of...
And I think some of the reasons why it's been difficult is finding people who actually have the Alzheimer's type pathology.
Yeah.
Because, as we mentioned before, there are other types of pathologies and probably other types of processes going on. And there have been great inroads in the last few years, including through the Australian Dementia Network, in getting better, what we call characterisation or better understanding of the pathologies that people who are living with dementia or perhaps have prodromal dementia are living with, including by use of biomarkers that you mentioned, Graeme. So scans of the brain that can show us whether there's amyloid plaque or not. And nowadays we're even looking at things that we can do more efficiently, such as blood biomarkers. But it's not that straightforward, I'd say, because if it was straightforward, we'd be there already. And it's not. And so I just wanted to highlight that just because your scan of amyloid is positive, does that always mean that you're going to go and develop dementia? 30% of people who are age 70 and above will have a positive scan. Not everyone's going to go and develop dementia. And if you look at people's brains, sometimes people we've told have Alzheimer's disease because we think they do, actually don't have it. So it's not that clear. We know that particularly as we get older and over the age of 80, it's more than one thing happening in our brain, which makes sense. Over time we accumulate different, changes. Better characterization of different types of pathological changes, I think, will help the field, because then we'll be able to identify the right people to put in the right clinical trial. And exactly what you said before, Graeme, in the way that you made that analogy with cancer, cancer's not one condition, is it? It's multiple conditions, and that's what we're trying to understand with dementia. It's not just Alzheimer's disease, it's often Alzheimer's disease or it's a different type of pathology.
But can we take the rust analysis, or the rust analogy that I used before? Because this is the problem I've got with some of the concerns raised over aducanumab. For my part, I wouldn't expect the removal of amyloid that has already caused a cognitive decline to suddenly result in an improvement in your cognitive ability, because the damage has been done. The rust has already, to use my analogy before, has already pitted the steel. So you know, the way I see it is this: is if you can remove the amyloid, then it's possible that what you'll do is slow down any further decline, cognitive decline. Indeed, if you could get it early enough, much earlier, and Stephanie's talked about the 2 decades, if you could get it early enough, then what it would say is we can actually stop the rust causing the problem. We can stop the amyloid causing the problem. Now, the problem we've got, of course, is that you might 20 years earlier detect that there's a prospect of amyloid forming on the brain of someone, but you don't go suddenly then applying aducanumab, for example, or one of those treatments with the risks associated with it, because the fact that amyloid might form on the brain, as Stephanie has pointed out, doesn't necessarily mean that it will cause Alzheimer's disease or whatever. And so the approach I adopt is to say, without having the technical expertise, Stephanie's got to say, if I'm showing cognitive decline, if I've been told through careful diagnosis that the problem is Alzheimer's disease, if I know that the Alzheimer's disease has been caused by amyloid on the brain, and that there was a drug that would stop the amyloid forming even further and would stop it, potentially remove it, it wouldn't necessarily improve my cognitive ability, bring it back to normal, but it might slow down or prevent further decline. That's when I would say to you, I would take the risk.
So putting aducanumab to one side, because I think it's a bit of a rabbit hole, but really the question that we're asking is like, can you fix, is it theoretically possible to fix dementia one day when we figure out how? Like, is there a future without dementia? Say yes. Say yes.
I think that there is. I think that there can be a future without some of these types
some of the
pathologies.
dementias.
And you know what, you've outlined so many things, you touched on, what do we need to do? We need to be able to identify which people who have Alzheimer's disease pathology are on that trajectory towards this making it, being a problem in 5, 10, 15 years, compared to the people for whom it's not going to be a problem. So we need, and there's a lot of research in working out what are the combination of factors, are there biomarkers? Are they types of cognitive profiles, neuroimaging, putting it all together? Who can we distinguish? Who's on that path and who isn't? And yes, I think that the future, there will be treatments. And I think regardless of the controversy of these medications, isn't it exciting that people are investing and researching? And regardless of this position, I think it does put a fire in the field. There are other monoclonal antibodies under investigation. And I guess we should also just be mindful that this is, there's a lot of supportive evidence, and this is what we're talking about, this rust and this tau, it's this amyloid cascade, the amyloid hypothesis. Is it proven beyond refute? No, it's not proven beyond refute. And so there may be other factors at play that end up leading to us having those changes in the brain that eventually lead to dementia. Our brains are wonderful, beautiful things, aren't they?
It's so complex. And it's actually, this is really playing into, we've got the same question from a couple of different people really asking about the role of family history of genetics in dementia and what people can be doing if they do have a family history to reduce their risk or identify early signs.
Yep, great question. So there's a really rare type of dementia, very rare, that is strongly genetic. It's what we call autosomal dominant inherited. If you have a parent, you have a 50% chance of inheriting this particular type of dementia. This is a type of dementia that is related to mutations in a protein that leads to these amyloid plaque formations. This type of dementia tends to have its onset much younger, even in 30s, 40s, and our 50s. And families usually know about this type of dementia. But what about other genetic factors? There are some genetic factors that are in the community that mean that we're at a higher risk than other people. But it's not a fait complete, and I think that's really important to understand. People who have a first-degree relative, a parent, a mum or a dad or a brother or a sister who've been diagnosed with dementia, are at a slightly higher risk compared to somebody who doesn't. That risk is probably mediated by the age of that person. So, having a parent who developed dementia in their 80s or 90s, not quite the same as somebody who developed dementia in their 60s or 70s. But even if you've inherited some genetic factors that do increase your risk, lifestyle factors probably do help to decrease that risk. And those lifestyle factors include having a healthy lifestyle, so being physically active and having a good diet and keeping your brain engaged and being compassionate to yourself as well and looking after yourself. This is not my saying, and I heard it listening to ABC radio one day actually, but I loved it. It said you can't change the hands that you're dealt, but you can change how you play the game. And the other thing that I think it was Professor Henry Brodati said, I love this as well, is that it's never too late to start exercising and having a healthy lifestyle, and it's never too early either. So I think that people should never write themselves off in any way. I think I forgot to mention before things like, not smoking as well, not drinking too much. These can be really helpful. So it's all those lifestyle things we do to look after our health in general. They're good for our brain as well.
Yeah. We've got heaps of questions coming through. I want to give this one to you, Graeme. How can medical professionals and community members help challenge misconceptions and stigma associated with dementia?
Oh, gosh.
In 2 minutes or less.
Yeah, 2 minutes or less, yeah. Okay, I think, first of all, understanding what the issues are. And those that have watched this program will get a much better understanding, I think, from some of the things that Stephanie's talked about and I've been trying to explain. So understanding is very, very important. Secondly, recognising that people who have been diagnosed with some form of dementia are really, people who can live in the community, engage in a social life, engage in a family life, indeed engage in a productive life at work for many, many years potentially. And that so the fact that someone's been diagnosed with dementia ought not to be a source of embarrassment or of shame. It ought to be something that you just recognise. It is a disease. And we can deal with those diseases. Importantly, as I said before, keep people who have been diagnosed with dementia in the community, living a social life for as long as possible. That does mean some modifications to their home to deal with the sorts of issues that can cause confusion and the like. And we've talked about a whole range of those, and Dementia Australia has some really good educational information about what can be done to deal with that. Don't simply take a position that says, oh, mum or dad or aunt or uncle or grandparent has been diagnosed with dementia, let's pop them into an aged care home. That is so wrong. If it's at all possible, with assistance and with respite care and the like, to keep people in the community, then that is important. It's one of the, if you think of all the things Stephanie's talked about, you can't do those when you are put into an aged care home. The exercise, the mental exercise, all those things start to disappear. So it's so important to keep people living at home for as long as possible. And recognise that, and I want to go back to something Stephanie said before, I think there's hope. Now, if you'd said this to me 5 years ago, I've said nonsense. It's not there. Now I think there is hope. There is the potential for us to find means, particularly of dealing with Alzheimer's disease, that can either stave it off or delay its onset in a way that it can be so devastating.
5 years. What a turnaround, right?
Can I just add to that as well? And I think I didn't mention this before, but after a diagnosis, what's so important is getting support with that diagnosis. That's right, yeah. And getting connected to a post-diagnostic support to learn. What I also hear from a lot of people living with dementia is the value of peer support and connecting with other people. There are even organisations for professionals who've been diagnosed with Alzheimer's to connect with one another. Important for family members and caregivers as well. And also to remember that when we're talking about dementia, often what we're talking about is changes in certain parts of thinking, not all, particularly in the early stages. And people are capable of doing so many things. So what's really exciting is now focus on things like cognitive re-enablement and rehabilitation and supporting people to maximise what they're doing. I love how you mentioned, Graeme, that some people with dementia are working, driving, caring for family, engaged, off to golf. One of the best parts of my role with the Australian Dementia Network is working with people with lived experience and having them contribute to what we're developing.
So important. It's a really important element, and it's part of the important element of research, which is that we should be engaging with, talking to and listening, importantly, to those who are living with dementia and who are able to tell us exactly what it is that they're going through. There are so many things that can be done, providing that providing we recognise what they are and we deal with it. Dementia Australia, for example, promotes the concept of dementia friends, of dementia-friendly communities, of dementia-friendly workplaces. It breaks my heart to hear of people, a colleague recently who was in a major law firm. He was diagnosed with dementia at a youngish age of 50-odd. And his partner said, well, I'm sorry, you'll have to cease. And I'm thinking, why? He's got every capacity, just compensate for any issues that might arise as a result of the early stages of cognitive decline. But why suddenly cast that individual out, of being able to be a very productive person in the community? So these are all very important elements. We've got major organisations, major banks, for example, that recognise this and are dealing with it. And it is, if I might say so, it's no different to dealing with any other person with any other form of disability.
Yeah.
We compensate for it, we deal with it, and we make life, as accommodating and as satisfying and as fulfilling as is at all possible. That's what we ought to be doing with people with dementia in the same way we do it for anyone with any other form of disability.
It really speaks to a lack of understanding in the community.
Yes,
Yeah.
it does.
That you don't know, so you just shut it down.
Yeah, absolutely. And it's about seeing people for being people and supporting people. And I love the idea of dementia-friendly communities and inclusive societies.
Yeah.
Including inclusive societies for people who might need additional support to function well cognitively. So important. I think it's something that we can all do in the way we speak to each other. And if we do have people amongst our circle who are struggling with memory and thinking, keeping engaged with those people.
Conversely, there's the family members of people living with dementia, and someone's asking in here how to manage burnout in carers.
Respite, and respite is so important. It's one of the things that, again, I keep talking about Dementia Australia, but Dementia Australia is focusing on is how we can provide proper respite care and assistance. It's why that helpline I mentioned before, 1-800-100-500, is so important, because it provides the process and the methods and the assistance that's necessary to be able to deal with respite. So you cannot possibly expect a loved one, no matter how caring they are for their parent or grandparent, whoever it might be, to be spending 24 hours a day, 7 days a week caring. So some form of respite care is required, and it is possible. It is, it's available, and it's one of the things that we talk about in terms of aged care reform, and it's not just aged care, because of course we have early onset dementia where this can be relevant, but it's saying, government, if you really want to do something here to help, and to help people with dementia live in the community longer, then provide some means of respite, provide the support that's needed to provide the respite care that is absolutely essential. Now, some places will do it, and I've seen situations where, for example, aged care homes, for example, might say, look, we can on 1 day a week or 2 days a week, we can take in people who have got dementia, and they can be part of the movie shows that we've got through the day, or the men or women sheds, as the case may be. In other words, the various productive activities, and that can give some respite to those of their loved ones who are caring for them. There are so many different ways they can do it. We've just got to be thinking more carefully about how we do it.
So I want to do a bit of a quick fire session with you, because we're running pretty short on time, but there's been lots of people asking questions about various things and whether they're protective.
Yeah.
I've had people asking about Sudoku, plant-based diets, music therapy. What else have I got in here for you? What do we know about different lifestyle factors and whether or not they're useful?
Yeah, all excellent questions. Mediterranean diet might have some effect. Things like Sudoku, often around things like cognitive training and online cognitive training, the studies seem to show that doing them you get better at those games. Do they translate to reduced risk of dementia? We probably don't have that evidence yet, but that's because that's also difficult to get. The advice I give is, if you enjoy it, do it. Sudoku you mentioned, plant-based diet you mentioned, what else?
Music therapy.
Yeah, again, if you enjoy it, do it. Probably not too many downsides, but if you're not a fan of Metallica and that's the music therapy you're doing, maybe give that one away.
I could do Metallica music therapy, that sounds fun.
But what you're talking about is all this sort of cognitive stimulation and that idea of, use it or lose it. And definitely if you enjoy doing these things and want to try new things, it can be useful, but we don't have definitive evidence to say this will definitely prevent dementia or this will definitely slow, but it may help. It may help. And I think another thing just to get across though is that you might live the most perfect life ever. And you might exercise and you might have the most perfect diet and you might keep yourself cognitively stimulated and do everything by the book. But you still might go on and develop dementia. It happens to so many people. Sometimes we can't prevent these things and it's not someone's fault. And I think that's something really important to get across. We really need to be compassionate to ourselves as human beings as well. None of us are perfect. And there are things in our life we can't change. What's important is we change the things that we can that are practical for us. And you mentioned before around caregiver stress. I just wanted to acknowledge that pretty much caregivers that I meet are pretty much the most amazing people I meet. They do an amazing job and I learn so much from listening to caregivers. One thing I've heard a caregiver say is at the beginning of a diagnosis, just accept all the help you can get, even if you don't think you need it. I've also heard that connecting with other caregivers can just be a way of helping. Do we have enough supports in our community to make that journey easy for every caregiver? I don't think we do. It is really hard, but there are packages of funding available through the government, as we talked about, and access to respite, sometimes day centres. It probably does vary on where you live. And it can be an amazingly fulfilling role, and caregivers do talk about the meaning and the purpose and the enjoyment of caring for someone they love, but it can also be unrelenting and exhausting as well.
And to the questioners that have asked, should we do Sudoku? Should we write? So I'm going to ask this question. What harm is there in doing Sudoku? What harm is there in having a good diet? What harm can you do by having good, sensible exercise? What harm can you do in having a good social life? So if you can do no harm and you enjoy it, as Stephanie says, do it, because it's just possible that it will stave off the cognitive decline that we also worry about.
Well, we want to know for sure, and this person has asked a great question to bring us home. Research is crucial in stopping dementia. What has been done, and what are the top 3 things that need to be done to support dementia research in Australia? Do you want to kick us off, Graeme?
Yeah. Well, first of all, let's recognise that if we're talking about drugs, I don't think it is within the capacity of any philanthropic research institution or government in Australia to be able to provide the necessary funds. We're talking about billions of dollars that are required, and that's really in the hands of Big Pharma. So let's just accept that, number one. We can, however, participate in trials of drugs, and we're doing so, and contributing an awful lot there. If I was to talk about the areas of research that I think are really important, then it seems to me, number one, diagnosis. How do we, the research we can do on early diagnosis is so important. Stephanie's outlined that, and I've tried to outline it as well. Let's find out much earlier on about the issues. 2 is research into care. How can we provide the best possible care for those who have been diagnosed with dementia in a way that will make their life as fulfilling and as satisfying and as happy as is possible. To give people, particularly loved ones that we are focusing on, in terms of our own families, give them the life that they deserve, right? So that seems to me to be the second important one. And then the third one, I think, is, and it's related to that, but it is, how can we keep people who have been diagnosed with dementia in the community, in their homes, in the workplace, in their social environment, much, much longer than we have always done in the past. So it seems to me they're the 3 important areas of research we can focus on.
Stephanie?
I'll answer in a slightly different way. I think that 3 key ways forward are A, ensuring that we have increasing involvement of people with lived experience in setting the research agenda and in design of research as well where appropriate. Secondly, I think that we need to elevate the status of dementia and integrate research and clinical practice more. So we talked about cancer before, and it was very common for people who are being treated for cancer to have the opportunity to participate in research studies, to have that opportunity to be part of a clinical trial. Does that happen for dementia? Not at all at the same level. And I think that's something that, Graeme, we're looking at with this national network of comprehensive dementia centres, actually co-locating and integrating clinical and academic activities so that there are opportunities for people to be involved in research studies, and there are opportunities for good research, and that will facilitate, clinical trials, be at prevention, be those clinical trials aimed at early treatment, diagnosis or care, as you outlined. And thirdly, I'm just going to go off a tangent, but if you're asking my opinion, and I always think about these things, so this is just my opinion today, but I'd like to understand, teasing out all of these different causes of dementia and understanding what they're doing in that pathogenesis, and then understanding how it interacts with the rest of the body as well. Because there's a lot of conundrums in dementia, and I think if we have understanding of those pathophysiology of not just AD, but how everything else interacts, then we'll be able to progress a little bit more with early diagnosis, with prevention, and with treatment.
30 seconds.
30 seconds. Stephanie's introduced comprehensive dementia centres. I think it's really worth talking about because that is, in one sense, one of the areas of where there's some real hope. An extraordinarily unique collaboration has been developed right around Australia of academics, of major teaching hospitals, of universities, of Dementia Australia or the Australian Dementia Network, which is the research network. So it's an extraordinary collaboration.
Including UNSW.
Including UNSW, to set up around Australia a whole network of comprehensive dementia centres. These are centres where you will, if you enter them, you will see Dementia Australia, you'll see researchers, part of the Australian Dementia Network, and others that are involved in this area. You will see clinicians, specialist clinicians, and you'll be able to get advice. They'll have visiting rooms and the like. It's the sort of thing where people who are showing or starting to show signs of a cognitive decline, or their GPs can say, look, here is somewhere you can go. Go first to the Dementia Australia helpline, and then from there you can be potentially directed to somewhere where there's this combination of clinical care and, importantly, research. Just today, I received advice about a particular dear friend of mine who has got a wonderful geriatrician assisting him, and she has said, look, we're going to do some tests to find out really what's going on, but importantly, I know where I can, potentially enroll you in some clinical trials that will potentially involve you in being able to not only assist in developing means of delay and of prevention, but also potentially assist you in the onset of the disease.
Well, we do have to leave it there. On behalf of UNSW Medicine and Health, thank you so much to Dr. Stephanie Ward and Professor Graeme Samuel. And it feels like it's an area that there's a lot to learn, but there's already a lot that we know. So thank you so much to everyone who joined in live for this discussion. Sorry that we didn't get to every one of the wonderful questions you submitted via Slido. Please look out for more information for future MedConnect events by following social media at UNSW Medicine. Thank you and good night.